my name is Alicia Zafar, and today I'm presenting the case study Asthma Attack. This follows Jaden Hunter, an 11-year-old with asthma who experienced severe exacerbation. We'll cover his clinical presentation, the underlying physiology, acute and long-term treatments, and the lessons learned. Case summary. Jaden's attack began after inhaling nitromethane exhaust at a racetrack. His quick relief inhaler only helped briefly. Overnight, his breathing worsened, and when he arrived at the ER, his oxygen saturation was 82%. This case illustrates how environmental triggers, airway inflammation, and lapses in preventative therapy can combine to produce a life-threatening event. Asthma pathophysiology. Background. In asthma, chronic inflammation thickens airway walls and increases mucus production. When exposed to triggers like irritant fumes or cold air, smooth muscle spasms cause bronchoconstriction. The combination of inflammation, mucus, and constriction narrows the airway lumen, dramatically increasing resistance to airflow. Clinical findings and measurements. On arrival, Jaden's SpO2 was 82%, corresponding to a PaO2 of roughly 40 millimeters mercury, while below the normal 80 to 100 millimeter mercury or Ag of healthy arterial blood. This low PaO2 Pa oxygen means less oxygen is loaded onto hemoglobin in the lungs and is delivered to tissues, leading to hypoxia symptoms such as fatigue and confusion. O2-HB dissociation curve. Here's the dissociation curve with Jaden's 82% saturation mark. At that point, the PaO2 is near 40 millimeter mercury. Normally at a PaO2 of 100 millimeter mercury, hemoglobin is over 95% saturated. Jaden's position on the curve shows both reduced oxygen uptake in the lungs and a lower reserve for tissue delivery. Mechanics of breathing. Airflow F equals the pressure difference delta P divided by resistance R. Normally, diaphragm contraction creates delta P to drive air in and out. In Jaden's case, R increased sharply because of narrowed airways, so F dropped. To compensate, he had to breathe faster and harder using accessory muscles, which is exhausting over time. Spirometry and exacerbation. Spirometry measures key lung volumes: tidal volume, the volume of normal breath; inspiratory reserve volume, IRV, extra air inhaled after normal inhalation; expiratory reserve volume, ERV, extra air exhaled after a normal exhalation. During an asthma attack, TV, IRV, and ERV all decrease because airway obstruction limits both inhalation and exhalation. Acute treatment and response. In the ER, Jaden received continuous nebulized albuterol, a B2 agonist that lowers airway resistance. He also got 20 mg of prednisone to rapidly reduce inflammation. Over the next hour, his SpO2 rose to 95%, indicating his PaO2 and overall oxygen delivery returned toward normal, so the nebulizer was discontinued. Long-term control and prevention. Advair combines fluticasone, a steroid to suppress inflammation, with salmeterol, a long-term acting bronchodilator, to keep airways open and inflamed tissue down. When taken twice daily, it maintains a higher baseline lung function and prevents nocturnal or trigger-induced exacerbations. Consistent adherence is critical. Jaden's missed doses likely contributed to this severe flare. Key take-home messages. Number 1. Understand the physiology. Airway resistance R, pressure delta P, and the O2-HB curve guide both diagnosis and treatment. Number 2. Differentiate therapies. Quick relief bronchodilators for acute attacks, long-acting inhalers for prevention. Emphasize adherence. Proper use of maintenance medications and trigger avoidance are essential to reduce ER visits and improve quality of life.